Anna K. Yagubian. I'm the Director of Education Programs for Adagio Health. We are so excited to have you all here for our first, one of our first breakout sessions this morning. We are going to be, our wonderful panelists are going to be speaking about the 2018 LGBTQ Health Needs Assessment. So we have with us this morning Adrian Shanker and Atticus Rank from the Bradbury Sullivan LGBT Community Center and Jennifer Keith from PHMC Research and Evaluation Group. Thank you again, and I will let them take it away.
Does this still count as good morning, or is it too late for that? For me, it's like when the conference started at 8 a.m., it was like the middle of the night. So I was very glad to get to like more of like an 11 o'clock situation. So today we're going to be talking about data. And one second for a technical glitch. Okay, so we're using two different systems. So we're so glad that you're all here to talk about data so early in the morning. Data is really the driver of so much of this work. So before we go into the data, we're going to talk a little bit about the history of it and also the importance of it. So first, as Todd and Jess Lavelle mentioned earlier, we started this process in 2015. So in 2015, Pennsylvania had prior to 2015, Pennsylvania had no localized comprehensive data on LGBT health disparities. And the problem with that was that it was very hard to make a case for why we needed to work for the improvement of queer health if we didn't have localized comprehensive data to be able to actually say what the need was. So we started in 2015 with a pilot project that we continued in 2016 to measure LGBT health disparities throughout Pennsylvania. And through that process, we learned that LGBT health disparities are pervasive, affecting every part of our body and every part of our lives. There was no health concern or body part that wasn't affected by health disparities, with one exception, which is access to health insurance, where the LGBT community actually did slightly better than the majority population, but that didn't affect our health outcomes, which were still worse, right? So even with that one area improved, we were still experiencing disparities. And those disparities included everything from tobacco and cancer and HIV to access to health care. Healthy People 2020 defines health equity for us as the attainment of the highest levels of health for all people. And this is really important because Healthy People 2020 doesn't say the highest levels of health for white people, or the highest levels of health for men, or the highest levels of health for cisgender people or heterosexual people. It says all people. So the goal that the federal government has set out is actually universal. It's a universal goal that all of us deserve health equity. It's not a goal that is just like a luxury. It's a goal that is a demand. That this is actually something we need. When we talk about health equity, we also have to put it in the context of privilege, because health equity in many ways is the achievement of health regardless of privilege. And in order to understand that, we have to talk a little bit about privilege. So I like to talk about shaped privilege, because sometimes when we talk about privilege, people tune out because they think, oh, that's not about me. And it is about you. But we're going to talk about shapes because it's less politicized. So there's a circle hole in the wall, and there's four shapes: a circle, a pentagon, a square, and a triangle. And the circle shape goes right through the circle shaped hole. And it's like, I don't know what you guys are complaining about. If you want to make it through, just be yourself. And the Pentagon's really confused. It's like, do you want me to cut off my spikes? And the square is just sad, which is, it's the thing that squares do, right? They're sad. And then, I thought that was good. And then the triangle is pissed. Right? The triangles are really angry. These are all legitimate reactions to have when we are experiencing the lack of privilege when we're navigating our health care and our access to care. Confusion, anger, and sadness. But the circle just can't get it. The circle's like, the system was made for me. Why wasn't it made for you? I don't get it. I don't get why you can't achieve the same access to this other side of the wall that I can access. And it's because the circle was made for the hole and the other shapes weren't. So what we did in 2018 was we redid the survey. So we started in 2015, but then we changed it up in 2018. And we did a statewide sample with the CDC's approved survey tool, a 7-week data collection, and a variety of community partners. And this tool was developed by a CDC-funded disparity network called LGBT Health Link. I want to stress that we did not develop the tool. There was a number of things that were incredibly problematic about the tool, which we will share with you, but we didn't write those problematic things. So the data collection partners included LGBT community-based organizations throughout Pennsylvania. And this is really important because so often when LGBT health data is collected, it's not collected authentically by the LGBT community. It's collected oftentimes by researchers or academic institutions or large healthcare institutions. And it's great that they're focusing on LGBT health. But what often lacks is LGBT people recruiting our peers and developing enough trust so that we can get a high enough sample size to really make an impact. And that's what we've done. We partnered with about 20 LGBT community-based organizations around Pennsylvania, mostly community-based, a couple statewide organizations as well, and 2 national organizations with their Pennsylvania recruitment. And we collected data through purposive convenience sampling, meaning we did outreach directly to our communities. We actually know how to find LGBT people in our communities, and so we reached out to them. Of course, the most important thing about why we do this is that without the data, the chatter don't matter, right? So Todd likes that one. Without getting data, we're just talking and pontificating. Once we have data, then we can forcefully make the case for improvement of our health. And that's what we're doing with this data now. We had almost the same sample size as the statewide sample that's often used as a baseline of the general population's health, called the Behavioral Risk Factor Surveillance System, which had 5,000 Pennsylvanians. We had just under 4,700 queer Pennsylvanians. And that's really important. And when we did that, we had Pennsylvanians from 64 out of 67 counties. There are, as Todd mentioned, queer people in the other 3. We could not find them. We tried really hard. We tried texting. We tried everything. So there are 3 very hard to navigate counties, but 64 out of 67 counties, over 800 zip codes are represented in our sample size. And a fairly geographically diverse sample with an admitted shortcoming in Northwest PA with a fewer than desired sample size there. I'm going to turn this over to Jen Keith, and she's going to go over the data itself.
All right, everybody ready? This is good stuff. So I do want to just point out, so since we know that this isn't a representative sample because it was a convenience sample, I do want to argue that this is a meaningful sample because of the size. And we have lots of opportunities that we'll be talking about throughout the presentation on how we can improve the sample when we do this again in 2020. So we're going to start right off with the sexual orientation question. You can see there's a mix of things in the graph, but what was the biggest finding here is that not everyone who is taking the survey, all of our respondents weren't seeing themselves in the categories that were available. And we had 538 people write in responses. So that is a clear signal that there weren't enough answer choices or in the question itself. So that's something that we can address, something we can go after. It's never going to be that there's no write-ins, but we want to look at what were the most common write-ins and make some changes. So pansexual, queer, and asexual were the ones that came up the most. All right, so we also had a self-identification question here that was not where we want it to be in the future. We can see that we have a mix of information here. There's certainly useful information, but definitely when we're asking about transgender, we don't want to have that separate from male-female. This is not the way folks think of themselves, and this is not going to be a way that we can talk about when we're talking about transgender health, we have some limits in the data with what we're able to say and do because we didn't ask this question well. You can see there's a write-ins here in this word cloud of other things that folks were writing in, and we categorize these as another when we're grouping, but there's lots and lots and lots of words, and these are all really, really important and part of identity. Age. So we have pretty much a bell curve here, you guys can see in the graph. We had a younger population overall. We had the larger age group between 25 and 49, but ultimately we had a range from 10 to 87. We know we want to do better in getting additional folks in our older communities to participate in the survey and be respondents, so that's something we can be working on. But all in all, this is just to give you a sense of who was able to respond, and also, of course, who wasn't. Race and ethnicity. This is a place we know we need to do a better job. Is that pretty clear on the slide? Yeah. So we know we had 3 out of 4 respondents were white. People could pick more than one race, but we see that that didn't happen very often. So this is an area we specifically need to make efforts. And if any of you are part of the groups who are helping with our data response, thank you so much. And let's keep working on it. And folks, if you weren't involved and you're part of LGBT community and services, let's get you on board for when we do the administration in 2020 so that we can make some improvements here. We need our communities of color to have a voice in this survey. The 6% of Hispanic respondents is actually right around where Pennsylvania hits, but we are going to be translating this survey into Spanish this year, so hopefully we can see some additional opportunities for response. Insurance. So insurance is often thought of as our, classic access to care category, our demographic of choice here. So what we see is that among our respondents, actually this is a largely insured group. We had about 6% of folks who weren't sure of their insurance status, which is important for us to know and think about how can we clarify and make sure folks are able to take advantage of insurance that they may have. But all in all, we're going to be challenging some of the general conclusions about, well, if you have insurance, we can equate that to access to care. We're going to see in some of our other slides that is not what's happening for our respondents in this survey. All right, making sure everything's matching up here. So in education, we also see that we have a largely educated group. This is another place where we want to make sure we're getting opportunities to as many folks as possible in future surveys, but this does tell us about our group who was able to respond. And we're going to jump into access to care here now. So one of the big indicators of access to care besides insurance is about if you have a personal health care provider. We had about 17% of our respondents who don't have anyone or are unsure if they think of anyone as their personal health care provider. That's something that we want to see that number change over time. There was also a lot of variation in whether or not respondents had advised their providers that they are LGBT. 45%, if we look at all of our respondents across the over 4,679, I know the number, 45% had discussed with all of their providers, 20.8 with some, and then 26.2 did not discuss with any provider. So over a quarter, 1 in 4 of our respondents had not discussed with any provider that they are LGBT. This number actually increases for our Black and African American respondents. This goes up to 29%. For our Hispanic respondents, it goes up to 29.9. But for our under 25, it goes all the way up to 46.4%. Had not discussed with any provider. So now we're getting really into that access to care. It's a little bit different if we're getting care for all needs and thinking about all of our opportunities for optimal health. So 1 in 4 also are sometimes, often, or always experiencing a healthcare provider reacting poorly when they come out as LGBT. So this isn't, there was this one time or like once in a while. This is sometimes, often, or always. And this has an impact. So then 56.8% of the respondents sometimes, often, or always fear a negative reaction by a healthcare provider if they come out. Now we're talking about access to care, right? This is something we have to make some changes. And this is, again, a largely insured group with a huge barrier. We also have disparities that we're seeing within our respondents. If 3 and 4 of our transgender and gender nonconforming respondents report this fear, that goes all the way up to 75%, 3 out of 4, compared to their cisgender counterparts. So among everyone, this is more than half. Among all our respondents, more than half, because up to 75% for important communities within the LGBT group. All right. We talked a little bit this morning about knowledge and competence among providers. This is, again, a big opportunity that we're able to quantify a little bit more now because of the survey and everybody who was able to respond. 1 in 3 are reporting their provider is not at all or just slightly competent. This is one of those slides where we should see so much opportunity. We do not want a bell curve in this graph. We want a clear ramp up to the extremely excellent, amazing, gold star, big smiley face on the door kind of thing, right? We want the ramp. We do not want a bell curve. We're not trying to go for the mediocre. We really want to see this grow and continue. It does mean that there are examples and there are providers, likely in Pennsylvania, who between the very and extremely. So we do have folks who are models here. That's really important. We are not starting from scratch, but we got to get everybody out of the not at all and the slightly. And not just settle for moderately here, and really move up to the very and extremely competent. All right, when we're thinking, that says this is about personal health and wellness, right? That slide? Okay. When we're thinking about this slide overall, what we're seeing is we have about, where's this one go? My slides got mixed. Okay, what we're having here is too many folks who are falling into the poor and fair category when we're thinking about self-reporting their own personal health. If we're thinking about the BRFSS, which Adrian was mentioning, we know that in that survey, there's not a very poor category, but the other 4 categories are the same. And we're seeing, we have about 6% and then so we're close to 35% in here who are categorizing their health as fair or poor. In Pennsylvania, among the general population with the BRFSS, that number is about 17%. So we're seeing a big difference. Now, it's a very different sample style, and we don't want to say like this is a true difference, but what we're seeing is we're getting a very different read when we do a survey specifically for the LGBTQ community than the general population, and we need to pay attention. Personal health and wellness. When we're thinking about BMI, we know that that is not the end-all be-all indicator of health, but it is one indicator, even if it's limited. We do see 2 out of 3 respondents who are classified as overweight or obese when we're looking only at our adult respondents. So 18 and over, we're using the NIH calculations here. This is actually pretty much right about where Pennsylvania is. It's slightly higher, but we're kind of running with Pennsylvania here in these categories. This is some good news. You guys ready for some good news? All right. So personal health and wellness. How many folks in here are providers or help with referring folks to services? All right, you should be psyched. This is the slide. Take a picture. This is going to go in your proposals. This is going to be really important for you to carry home. There is so much interest in increasing healthy living strategies. And this wasn't just a random question that we assumed everyone knew what a healthy living strategy was. We actually gave some examples in this question. So that was a thumbs up for this question here. The examples were such as healthy eating, exercise, tobacco cessation, etc. So folks had some grounding here, and they were able to respond with some context to this question. And we're seeing there was like 98% of folks were like, yeah, I'm interested. So if we're thinking about contemplation and pre-contemplation, these folks aren't pre-contemplators. They are contemplating. Folks are ready. And then you'll see that there was so many folks, over 40% of folks falling in the very category. And we have at least 26% of folks who are extremely ready. They're probably the folks knocking on the doors right now. But this is really good news. There is interest, there is attention, and there is momentum for incorporating healthy living strategies. Screenings. Screenings are a really important thing. They are super nuanced and difficult to talk about in a single slide. So I'll apologize up front for being, skimming the surface here. But when we think about recommendations for screenings, they change over time. They may vary by all kinds of things, including personal health risk, including family health risk, including gender-affirming hormone therapy, other hormone intake. All kinds of things may influence what your personal actual recommendation might be from a provider. We don't have all of that information in the survey, so we were looking at things a little less nuanced. So we anchored on ever screened versus never screened. So when you see the orange in here, that's never screened. So the gray isn't necessarily like awesome, great news, because you may not be up to date on screenings, but it means that you have had the screening before. So this is a couple screenings that were asked about in the survey. So we have diabetes. We know that with 2 out of 3 respondents falling into the overweight or obese category, we probably should be seeing less orange in the diabetes testing categories here for screening. For HIV testing, we see really our gay respondents were at 14.3. That's the only really good news we're seeing here. Overall, to have 30% of our respondents have never been tested, that's probably some more work to do. And we're seeing among our transgender respondents, it goes up to 41.3% never having been tested. Mammograms and cervical pap tests, this ramp, the color ramp that you're seeing here, this is really speaking to disparities within the LGBT population, that the numbers would change so drastically based on age and identification. General satisfaction. This is an important question. This is asked on so many surveys that whatever kind of survey you're looking at, this question's probably going to make the list. It's an indicator, one of the broadest of mental health. We don't want to have 1 in 4 LGBT people in Pennsylvania falling into the dissatisfied and very dissatisfied category. We actually have quite a bit of information in the survey about mental health, so we're going to dig into some of the other components as well. We have 1 in 6 respondents reported that they rarely or never are getting the support that they need. That's rough. So we want everybody to be in that usually and always. Even the sometimes is really not where we want to aim. This is another one. We don't want a bell curve. We want a clear ramp. And when we're talking about never and rarely, that's a really high risk area to be in, to never or rarely get the support that you need. So this is something we need to be talking about. In the past 12 months, we had respondents, about 77.6, talk about that they experience any type of mental health condition or problem. That number actually really varies as well. It's a high number, right? So that's our overall number. It goes down, actually, among our older respondents, it goes down to 47.7. So still a significant proportion, but much, much lower than 77. Unfortunately, when we're looking at our transgender respondents and our under 25, these numbers go into the 90s. That's okay, except when we talk about received counseling or treatment, that number should really be following the top number. So it's not that the top number should be a certain place, it's just that we should have some following with that when we're thinking about treatment and care as well. We do see some differences between cisgender and non-cisgender folks. When we're looking at counseling and treatment, we see some differences. Actually, our younger folks are getting more treatment than our older folks. So this is, there's a lot of information here. It's hard to really dig into all of it, but these are the kinds of things we need to be talking about. Mental health is an important part of LGBT health and everyone's health, and when we're talking about optimal health for all folks, it's very much on the table. HIV. What we're seeing, we talked about how 30% of the folks in our survey had never been tested. We had some good news there, but the big take-home part here, things we need to be, using these data. Of course, we're not doing this just so we have like, oh, that's interesting. We actually want to use these data. So what we found is that our respondents were telling us they would feel most comfortable getting an HIV test in an LGBT community-based setting, or with a primary healthcare provider. So are there ways we can support testing, anew to make sure that folks are able to get tested as recommended, not just ever versus never? Current tobacco use. We heard a little bit about this morning, that this isn't always something that we're ready to talk about, but we see large disparities here compared to Pennsylvania overall. When we're thinking about cigarettes, the number here is about 30% of our respondents were using cigarettes. And among the general population, it's closer to 18%. So this is something we need to be talking about and make sure it's on the list of things that get priority. When we think about our transgender respondents, the number goes up to 33.3. Our Black and African American respondents, it goes up to 39. And our under 25 group, it goes up to 41.7. We also have this broken down. If you brought your magnifying glass, you can see that there's variation by region as well. So if we're looking at age, region, and LGBT and transgender, gender nonconforming, we have lots of different, you can see peaks and valleys here, and regional variation, which I'm sure all of you are familiar with. This is a broad group from all over Pennsylvania, but it is something for us to be keeping in mind, even if you thought like, well, I actually thought the cigarette smoking rate was going to be much higher. In your area, it might be. So we know it's higher than the general population, but it may even be at increased risk based on geography or in coordination with geography. Tobacco opinion. So we had a series of questions here that we're asking folks about willingness to participate in smoke-free events, go to smoke-free venues. There was really a lot of support. And in this case, I don't know about all of you, but neutrality, like, I'm okay with neutrality here. Like, agree or neutral is usually a win. That means like, yeah, I would go. It's no big deal. So if we're thinking about, I would likely go to a smoke-free Pride event, having 65% of our folks agree, and then almost another 30% like, yeah, whatever. That's great. That's a large percentage of folks in a target population here for a Pride event who are on board and ready to be at a smoke-free event. Substance use and alcohol. We did have some significant findings in the binge drinking area. So we had about 43% of our respondents who at some point in the past year had reported that binge drinking, and about 1 in 10 reported daily or weekly binge drinking. Something for us to be talking about. Marijuana use was the most reported drug use, but we had responses for all of the 12 different drugs that were mentioned. So there was just a lot of variation. It was harder to see when things were broken out by drug category. It was harder to see trends here. But we do want to make sure that this is something that we are aware of and thinking about. Cancer. We had several different cancer questions. One of the newer questions was about indoor tanning, and we had 4 in 10 who were reporting indoor tanning. This was more common among our cisgender males than our cisgender females, and the least common among our transgender and gender nonconforming respondents. But this is an area where when we also look at 1 in 10 respondents were reporting a cancer diagnosis during their lifetime, and the most common one by far was skin cancer. So these things are relevant and can be part of the conversation in a new way. With our age group, it's not uncommon that skin cancer was top on the list, but when we're seeing it's also following with indoor tanning use and not using sunblock on a regular basis, we know that this is preventable skin cancer. We actually, just in case it wasn't clear, every cancer that we did ask about, and I believe there were 11, did have some respondents report that yes, they have been diagnosed in their lifetime. And cancer survivor support systems, there was a series of questions here where folks were asked about their thoughts on different kinds of supports for cancer survivors, and really there was just, you can see tons and tons of orange here, lots, just overwhelming agreement that there needs to be more supports for LGBT cancer survivors. Perceptions on health, we're actually going to go, this ends up taking us back to some of the discussion about mental health. There was 15 options on this question where folks were asked to rate or check off what was most important, the top 3 issues for the LGBT community. What we found was depression, suicide, and isolation were the top 3 overall. These all relate to mental health in different ways, right? Access to welcoming care and HIV/AIDS had over a quarter, but you can see that these other 3 really rise to the top. No matter how we sliced it, no matter what demographic group we were looking at, depression was in the top 3. These things stay at the top. There's large agreement. So while we have disparities within the LGBT community in lots of different areas, we know that mental health is a priority based on our respondents from this survey. We found that there were some categories where there was that ramp again of when things become important. So if alcohol, for example, starts off as not so important, it makes it into the top 3 steady growth, and among our older respondents, that was made the top 3. Bullying had the opposite, where among our younger respondents, it's in the top 3, and that goes down over time. But depression especially stays up at the top, and actually, no matter how we look at it, it never went below 44%. We also had some really important feedback about how to ask this question, ways to think about doing this in the future. There was, again, when we had the information and questions about drug use, there was things broken down by specific drug name or type instead of having a general addiction category. That may have changed the results in some way if there was a better grouping of addiction. There was also lots of write-ins here where folks had other top priorities, and these are really important for us to be discussing and reporting as well. And, excuse me. In summary, we really just want to say there's a lot of different things going on. This is very layered information that we got back in this survey, but there's lots of resiliency here that we can see as well. And especially that one, remember the good news slide, take that one home, we're going to need that. There's more work to do. We do not have, where we have challenges, if we dig deeper, we can see even more challenges when we're thinking about health disparities. And no matter what, anytime we're gathering this information in the future, we need to do a better job for collecting data from communities of color and older adults. So we have some calls to action for us for getting better data. We have calls to action for use of these data that we do have, even if they have limitations.
So as I'm going through the recommendations, I just want to ask for some hand raising first, so that I know which recommendations might apply most in this room. Raise your hand if you would identify yourself as a healthcare professional, a clinician, or a care provider. Wow, that's a lot bigger of a percentage than I thought. If you would identify yourself as either a policymaker or either public or private, so at an insurance company, a health network, or a government entity. A couple. How about someone who self-identifies as an activist around healthcare in general? Okay. So these recommendations were written for a variety of different audiences because they're recommendations that are for the public. I should also say the slides are in your app as well, but the entire data report is available for free download on livehealthypa.com/LGBT. I'll say it one more time, livehealthypa.com/LGBT, and it's the 2018 Pennsylvania report, but also all the 2015 and 16 regional reports also live there, and that's the Department of Health's chronic disease website. So some of these recommendations include that there needs to be better connections to LGBT competent providers, both medically and culturally competent providers. We need to have stronger referral systems. We need to have better knowledge about who is a provider that is specializing in LGBT care, and it needs to go a little farther than just like a rainbow sticker in the doctor's office. We need healthcare consumers to adequately and efficiently be able to find care providers that are well suited to care for them. We need to promote health screening discussions, especially around cancer screenings, but also HIV screenings. Prioritizing chronic disease prevention is incredibly important for the LGBT patient population, given the worsened health outcomes that we're already seeing. It's pretty evident that we'll be experiencing higher levels of chronic disease if we're not already, and we need the prevention to really be there and funded to be there. And that includes funding for tobacco prevention and cessation work, funding for healthy eating and active living, funding for the prevention mechanisms that allow for communities to live healthier lives, promoting tobacco cessation opportunities, and especially in smaller communities, identifying community-wide mental health support systems, continued and enhanced data collection, and as we continue this in 2020, we're specifically putting subcontracted funds into trans communities, communities of color, and efforts to specifically reach LGBT older adults and LGBT youth. And partnering with community-based organizations, and that one should have like a big red underline. If you're not an LGBT organization, please partner with your local one before just trying to start serving the LGBT patient population. We really know how to reach our communities. I want to give a little shout out to Kathy Cameron, who's right here from Washington County. So there's LGBT centers around the state. There's also pride festivals around the state. Work with one of them because it'll be much better result if you partner. And I know there's just a couple minutes left, and as we're closing, I want to bring Atticus up, Atticus Rank, our Health Programs and Supportive Service Manager at Bradbury Sullivan Center, who's going to share how we're utilizing this data.
Okay, so I also want to say first that I don't do this alone, thanks to Adrian and also Anne-Marie, who is our Tobacco Education and Outreach Coordinator. So what do we actually do with all of this data? Okay, all right, so... Yeah, okay. All right, so how are data being used? So some of it is a social norming campaign, Living Proudly, Living Longer, Quitline promotion, smoke-free prides, LGBT engagement with TRUE, which is the Tobacco Resistance Unit, gay bar outreach, prevention education for the LGBT community, and training tobacco dependence treatment providers, which I'll go into detail in these slides. So this is our LGBT smoke-free campaign. We have the postcards out on our table. I encourage you to check it out. I also encourage you to check out our poster, which also goes into detail about this. So we have our Living Proudly, Living Longer campaign, and we've purposely made this campaign so it doesn't seem like a lot of the typical narrative when it comes to tobacco work is if you smoke, you will die. And we don't like that sort of kind of message. We really like to say, like, look how far we've come and look how much we have to live for. So we've got billboards, postcards, LGBT media like the Lehigh Valley Gay Journal and Philly Gay News, and then, of course, our social media promotions as well. This is our bracelets. We also have the bracelets still out on the table, so I encourage you to check it out. So we put our Quitline cards in LGBT spaces, of course, our own center and community-based organizations around the state. These silicone bracelets are very popular. It says hashtag tobacco-free queers. It has the 1-800-QUIT-NOW number on it, which is, of course, the Pennsylvania Free Quit line. And then on the inside has Bradbury Sullivan Center. Oh, I didn't press the clicker. Now you can see the bracelets, so you should check them out. They're very popular at our Pride events, and then our website's on the inside. Okay, this is our Pride work. So smoke-free prides, we've helped many smoke-free prides across the state go 100% smoke-free through our efforts, and of course with our help from Health Promotion Council and American Lung Association. So some of the prides are Lancaster, Reading, New Hope, Chester County, Doylestown, which is new for the first time this year, Philadelphia, Erie, Allentown, Scranton, Milford, Ellsberg, Harrisburg, York, and Franklin. So what we do at each of these prides, just very briefly, so we have signage throughout the festival. You can see the smoke-free zone. We also have the same pride signs at all of the festivals. We have a speaking opportunity on stage where we briefly discuss why it's important that LGBT people are smoke-free, and we create smoke-free spaces. We're really about trying to change the culture around being smoke-free in the LGBT community, because we so often think of queer-specific spaces for LGBT people, they're often consuming alcohol or tobacco at these locations. So what we're trying to do is change the culture and say that smoking is not part of being LGBT. So we have an announcement on the website and email. We have our own Bradbury Sullivan sign on the stage. And then we have a lot of swag, which is really new this year. So we have tote bags that have a smoke-free message. We have sunglasses that say our logo on one side and our campaign on the other side. We have buttons. We also have hats, which we're giving out to our schools. We have a big standing banner. And for the first time this year, we have a Snapchat filter. So what we can do is we have a Snapchat filter, and it's got this rainbow around it, and it says LGBT smoke-free on it. And then that reaches a large audience as well, and we've geo-located it around each of the prides. Here's some of our bar outreach. So we partner with a drag performer who goes out specifically into gay bars and incorporates anti-tobacco messaging into her performance. So she can say really fun things like, oh, I'm looking for someone to take home tonight, but you gotta be smoke-free. So she can incorporate these fun messages into her performance. So we also have these LGBT smoke-free stickers, which she gives out to everybody. So it helps us, we do that at our prides as well, and that really helps show the message that this is a smoke-free space in case they can't see the 12 signs we have around. They can also see that almost everybody we try to sticker with a LGBT smoke-free. And we also have 2 bars that have now gone smoke-free. Stallions in Harrisburg and Stonewall in Allentown have gone smoke-free, partly because of our efforts by saying you're not going to lose any business by going smoke-free, that a lot of people want to be smoke-free, want to engage in smoke-free spaces. Finally, our prevention education. So a lot of the work that we do, and Anne-Marie does too, is the health prevention education. So we do health promotion games to educate LGBT high school and college students. So what we do is we go into high school and college gay straight alliance clubs, which is the LGBT clubs. And what we do is we play a game, either like Family Feud or Jeopardy. And it's just this fun, interactive way to incorporate tobacco cessation and prevention into a fun, interactive presentation. And we also do health promotion art projects, some of which is like World No Tobacco Day, Great American Smokeout, Kick Butts Day, and just this past week, Anne-Marie did a presentation with Strayer Middle School, which is in one of our counties, and they did an art project on what does it mean to be smoke-free in the LGBT community. True engagement, so True, the tobacco resistance unit, I know Molly is here somewhere. So our goal was to get 15 students signed up for True throughout the course of the year. The year's almost over, and we have 91 students who have signed up, so we're very happy with our numbers. And then we've also trained tobacco dependence treatment providers in the Northwest and Southeast. So what we do is we say, yes, you're providing tobacco cessation services. The LGBT community smokes at higher rates. How can we incorporate your services into LGBT competent services? And then provider engagement at Pride. So all of the Prides that we go to, we also partner with a local tobacco treatment provider who's there next to us. So we have a booth with all of our swag and our tobacco messaging, and then right next to us is a tobacco dependence treatment provider. So if somebody has questions, because we're not clinicians and we don't directly provide those type of services, what we can say then is, if you're interested in quitting, here's someone who can help you right now, and you can set up a meeting with them and talk with them right there. Areas of continued opportunity. The 2020 needs assessment, we're going to have, as Jen mentioned, a Spanish language version and improve demographic diversity so that we can hopefully try to reach the communities of color and the older adults that we need to reach. Increased pressure for Pittsburgh Prides to go smoke-free. Promotion of smoke-free gay bars outside of Philadelphia. Like we said, two of the bars have so far gone smoke-free. And stronger LGBT community engagement for Tobacco 21, which is raising the age of cigarettes to 21, which includes vapes and ENDS, which is the electronic nicotine delivery system, and clean indoor air. So thank you to all respondents for your time, feedback, and ideas, and to the 2018 data collection partners, and special thanks to Centerlink's LGBT Health Link program for survey oversight and administration. So this is our contact information, and I believe it's questions. Oh, I forgot that part.
We had one more Pride Festival Go Smoke Free kind of after the slides were submitted, and that was People's Pride in Pittsburgh. So one of the two Pride festivals in Southwest PA did go smoke-free. It just happened after the PowerPoint was made. So I don't know if CR is here, but we're very appreciative of Tobacco-Free Allegheny and Sisters Pittsburgh for making that happen. But the big Pride festival, Pittsburgh Pride, still is a smoky event, and it's a problem that our festivals are not all smoke-free in Pennsylvania yet. Any of the three of us are happy to take any questions, either right now or individually after the presentation. Yes.
I was curious, you talked about LGBTQ folks having higher rates of access to insurance, but not higher, I guess, compliance for outcomes. And I was wondering if we're going to be looking at how to increase those outcomes.
Yeah, so the question, just so that everyone can hear, was health insurance, higher rates of being insured, lower, still worsen health outcomes. And I'm not sure it's as much about adherence to anything in particular as much as it's that access to health insurance is not the lead indicator of LGBT people's health, because there are so many barriers to care that health insurance is only one. And there are many problems with that. So one of them is that health insurance doesn't always cover unique LGBT health needs. So that's number one. So an example of that would be that the Affordable Care Act mandated that essential health benefits are covered with zero cost, $0 deductible. So cervical pap test, for example, is an essential health benefit. An anal pap test is not, even though it's the same exact procedure. And it's $140 out of pocket with most insurers, whereas cervical pap test is $0 copay, $0 deductible. So health insurance, it doesn't always cover LGBT needs. The other piece is that the lack of people being out to their providers and the lack of knowledge of who is an LGBT welcoming provider. There are some mandates that could come down from the state, but there's also training that health networks and individual clinicians can do to ensure that they are prepared to provide high quality care. I think that the lack of the quality care is really the big indicator, more so than access to insurance. Obviously, if somebody doesn't have insurance, that's going to be their barrier to care. And every LGBT person's different. So one person might feel very comfortable with their doctor, another person might not. But the reality is that in most of Pennsylvania, there's a lack of ability to find a culturally affirming provider. Do either of you have an addition to that? Okay. Any other questions? Okay, well, we'll be happy to answer some questions individually during lunch if anyone has any. Thank you so much. The link to download the full report, I read it out, but it's also right here, and we'll leave this up here for a couple minutes so you can write it down. LiveHealthyPA, either .com or .org/LGBT.